Okay, I'd like to welcome everybody. I'm David Cowell. I'm the medical director at Coastal Hospice, and we've got a sequence of 5 lectures which have been entitled Hospice Beyond the Basics. Today we're going to talk about pain management at end of life. The other lectures in the series are palliative care, non-pain symptom management, palliative sedation, and thanatology. And we are going to be recording them, so there'll be an opportunity for people that don't get to attend these lectures to catch up with them later. We do have one schedule change, and that's the schedule for the November 7th lecture, Palliative Sedation, which was supposed to be here. We're going to have it at the auditorium at Hospice at the Lake on the 4th, for both the Lake and here. Pain management is one of the critical problems that we see at end of life. It's usually the first symptom that we need to address, and before we can move on to dealing with a lot of the other psychosocial and spiritual problems at end of life, we need to get the physical symptoms under control first. And pain is very often the first problem that we deal with. One of the keys to management of hospice patients, and particularly pain management, is something called portmanteau. And portmanteau is a European term which means a small suitcase. So when you go traveling, you want to take a small suitcase, but you want to take everything that you need in that suitcase. And that's the same principle that we apply to hospice care. What do you think the average number of medications that a nursing home patient is on? Anybody have any clue? 18 to 20 medications. Most of them useless. And the attitude is you never stop anything. You always add something else. So people end up with 4 or 5 medications for one problem, when ideally they should be on one medication that treats 4 or 5 different problems. So that's the basic principle of portmanteau, is to simplify things, get rid of unnecessary medications, and get a more focused, logical, small suitcase of medications. So we want medications that have multiple therapeutic effects. We want to minimize drug-drug interactions. The more medications someone is on, the more chance of drug-drug interactions, the more chances we're going to have medications that they're going to have side effects from. We want favorable risk to these medications. People are at the end of their life. We're not willing to tolerate a lot of toxicity from our own treatment. And we want to provide convenient dosing schedule. We want to make it simple. And we, as always in any kind of healthcare, we need to be cost efficient. That's something that tends to be lost in modern medicine, but we only have a finite number of healthcare dollars to spend on anyone, and we need to spend those dollars wisely. Every dollar we waste on useless treatment is a dollar that we could have spent for someone else. So let's always think about our costs. If you only need one slide on chronic pain management, this is the slide. This is just sort of the basic principles of chronic pain. The first is people need a long-acting narcotic by the clock. These people have pain all the time. Going a short-acting narcotic every 4 hours, which is the way we were all taught to manage pain on post-operative patients, is absolutely useless in a hospice care setting. That means they're sitting there looking at the clock as the pain's getting worse and worse, waiting for the 4 hours to go by. That's not the way we treat people at end of life. We want a long-acting medication that's going to maintain a constant blood level. So they may be in every 8-hour schedule or every 12-hour schedule, whether they hurt or not. So they have a constant blood level of the narcotic. We want to use a fast-acting narcotic for breakthrough or incident pain. And the difference between breakthrough and incident pain is important. Breakthrough pain is what we usually think of as the medicine's wearing off and they need an extra dose. But very often we ignore incident pain, and the hospital is terrible about ignoring incident pain. Incident pain is when you do something that predictably causes pain. I hurt every time they give me my bath in the morning. So the attitude in the hospital is, well, give them the bath, wait till they hurt, then give them something for pain. The approach to incident pain is know that that activity is going to cause pain, give them the medicine 30 minutes before you give them their bath so they don't hurt at all. Common sense gets missed all the time, and so many nurses just don't respect the difference between those two terms. All patients taking chronic narcotics are going to be constipated. And everyone needs to be treated for their constipation if they're on chronic narcotics, unless they've got C. diff or something, they've got explosive diarrhea. Dame Cicely Saunders, who was the head of the first hospice in London, used to lecture her residents every year, and she would say, the hand that writes for the narcotics but fails to write for the bowel regimen will be the same hand that gets at 3 a.m. to disimpact the patient. And so that's kind of a good motivator to treat the constipation. And I tell patients, I don't care what your bowel habits were before. For the rest of your life, you're going to have a bowel movement every day. And we're going to adjust your medicines till you have a bowel movement every day. Interestingly, the pharmaceutical industry, and I don't want to get off too much on what an evil empire that is, but they've come out with this new medication that they're marketing for constipation. It's basically a peripheral narcotic receptor blocker. It's very expensive. It has to be given by injection. And Senna works just great and at a fraction of the cost. And so they're marketing a new product at great expense to deal with something that we have good medicines for already. But they've been chasing me recently trying to convince hospice that we should start using this new product. But at any rate, everybody on chronic narcotics needs to be on a bowel regimen. We need to treat neuropathic pain. We'll talk about what neuropathic pain is here in a couple of minutes. But it is a type of pain that we grossly underestimate in our cancer patients. We need to treat the non-physical pain. People project their non-physical symptoms and express them to us as physical pain. And we need to recognize that all the narcotics in the world aren't going to solve those problems. The patient who is afraid he is going, just to give you one example, is going to burn in hell for eternity because he had an extramarital affair 10 years ago, and he's not going to tell you about that affair, he's going to tell you how bad his hip hurts. And you're going to keep increasing his narcotics and it's not going to make any difference. And so we need to get our counseling staff, our chaplains, to work on their non-physical issues, something I get sucked into all the time. Myoclonus is a twitching motion, and it is caused by opium-derived narcotics metabolites. And it gets interpreted as pain. All opium-derived narcotics have these toxic metabolites. The worst is meperidine or Demerol. In fact, this used to be called the Demerol twitchies. And what happens is the nurse or the doctor says, oh, the patient has more pain because they're having the myoclonus, which is described as pain. And so you increase the Demerol. You increase the Demerol, more metabolites, more myoclonus, increase the Demerol again, and you're just caught on this upward spiral. So we need to monitor patients who are taking opium-derived narcotics for myoclonus and recognize that it's not cancer-caused pain or what have you, it's a drug toxicity. It's missed all the time. 2 cardinal rules is, 1, we should not use Demerol. Enlightened pharmacies, enlightened hospitals have eliminated Demerol from their formulary. I've been working on it at PRMC for 10 years, maybe before I die. It will be eliminated from the formulary. IM injections hurt. We probably all had IM injections. Narcotics are absorbed just as well subcutaneously as they are intramuscularly. If it has to be given by injection, it should be given subcutaneously. And again, this is a big fight. Why take somebody who's in pain and doing something for them that's going to make them hurt more? Common sense, but it gets done all the time. How do patients describe their pain? Maybe inconsistently, maybe variably. It may be influenced by a lot of things: psychosocial, social, cultural, physical. It may conflict with the family's reports. There may be all kinds of reasons for that. The family may hate the patient and want them to suffer. The family may want them to be awake, and so they want to minimize their pain because they're afraid the pain medicine you're going to give them is to sedate them. If you've ever read Sam Shem's The House of God, in the back there's the 10 rules of the House of God. First rule is the patient is the one with the disease. You know, the family's entitled to opinion, but they're not entitled to a vote. The patient says they're in a lot of pain, they're in a lot of pain. I don't care what the aunts and uncles have to say. We have no blood test for pain. We have no scan for pain. The only way we can tell how much pain someone's having is by what they tell us. And so their report of pain is the gold standard. It's the only way we can measure the pain. And we need to use pain scales consistently. What are pain scales? The 10 scale, there's a lot of different ways you can do this. You can, Hospice script has these little rulers that have the 1 to 10 scale. They also have the smiley faces and frowny faces on them. The problem with the smiley frowny faces is that gets interpreted as sadness. And we're not measuring depression, we're measuring how much pain. So you have to be careful they're not misinterpreting that. The example I like to tell people is if your pain score is about a 3, well then you probably want to go to your medicine cabinet and look for some Tylenol. If your pain score is a 5, you're starting to get worried and you're going to call your doctor and make an appointment. If your pain scale is about 7, it's time to call 911. Pain scales of 9, it's time to scream. As I said, you can use the visual analog, but just be careful people aren't interpreting that as a sadness scale. You need to realize that counting to 10 is a reasonably sophisticated concept of numbers, and some people may not be able to comprehend a 10. Certainly some young children, and we certainly have some developmentally challenged adults. If they have to take their shoes and socks off to count, they probably aren't going to do well with a 10 scale. You can just draw a 10 centimeter line on a piece of paper and tell them this is no pain and this is the worst pain you can imagine, and where are they on that line, and make a mark, and then get your ruler out and convert it to a number. Pain needs to be looked at as a 5th vital sign, and so we need to be if we're going to treat pain, we've got to be recording it consistently. I know you all hate neuroanatomy, but we need to talk about a little bit of neuroanatomy so you understand how the medications work. So here we have a toe that's stepping on a tack, and we're going to trace how that pain in your big toe gets to your brain. And it has to have a minimum of 3 neurons. The first neuron starts where the tack hits the toe, and it goes to the dorsal horn of the spinal cord, where there's a synapse with a second order neuron right there. The second order neuron then generally crosses over to the other side of the spinal cord and ascends in a spinal tract to the thalamus deep in the brain. And the third order neuron goes from the thalamus to the cortex, the sensory cortex of the brain, where you actually perceive the pain. And what we're most interested in here is the synapse between the first and second order neuron, because that's where most of our medications are effective. That's where the major block is when we use narcotics. Now, the most common kind of pain that we deal with most of the time is called nociceptive pain. And this is when you injure non-neurologic tissue. It is transmitted, as we said, by this gate between this first and second order neuron. So you just imagine that synapse in the dorsal horn of the spinal cord. It could be somatic, bones, soft tissue, muscle, skin. It could be deep viscera, your intestinal tract, heart, lungs, that sort of thing. People usually describe it as an aching or a throbbing pain. And opium-derived narcotics like morphine, Demerol, relieve the pain because they cause a block right at that synapse between the first and second order neuron. And that's often called the opioid gate because it blocks that kind of pain. Now, this actually is my abdominal CT scan from a few months back. And here is Godzilla, my kidney stone. And as it was popping in and out of the proximal ureter, I had horrible colicky pain. So a classic example of nociceptive pain. And narcotics were my best friend there for a while. It is just amazing. 20 minutes after taking an oral dose, the pain would just stop for a few hours. It's all gone now, by the way. Neuropathic pain is injury to neurologic tissue. And probably 40% of our patients are cancer patients. And the cancers don't care whether they're eating through normal viscera or they're eating through nerves. They just grow right through everything. And so neuropathic pain is a big component of the pain we see, and a big component of the pain syndromes. The textbooks say that neuropathic pain is burning, stinging, shooting. The reality is when people start having trouble describing their pain, that's a good tip-off that it's neuropathic. It's horrible, but you just can't put words to it. It often follows a dermatomal pattern or a phantom pattern. Good example of a dermatomal pattern is somebody that has herpes zoster or shingles. The virus is in the nerve root, say of an intercostal nerve, and the patients will have pain following the dermatome, following the pattern that that nerve innervates. Phantom pain is pain where a body part used to be. Combat surgeons deal with phantom pain all the time with people that have their arms and legs blown off in war situations. And they hurt where their leg used to be or where their arm used to be. But we also see it in a lot of aggressive cancer operations. You hear women describing what sounds like chest wall pain, but when you really try to localize it, you realize it's outside their body. It's where their breast used to be when they had a mastectomy. So the pain may be actually out here, and then there's beyond where their body normally is, because the nerves still think there's tissue there. Patients that have had an A&P resection for anal cancer or rectal cancer may have pain where their anus used to be, even though it's been surgically removed. So phantom pain isn't just following leg amputations. About a third of patients with neuropathic pain will have allodynia, and this is something that you all have seen all the time. Allodynia is when non-painful stimuli cause pain. You go to comfort a patient or examine a patient and you talk to them and you put your hand on their shoulder and they jump and scream in pain. That light touch was interpreted as pain. That's allodynia, a clue that the patient has neuropathic pain. What happens, and again, go back to that image of the first order neuron synapsing with the second order neuron. What happens in neuropathic pain is there are these little short neurons called interneurons, and these bypass that path from the first to the second order neuron. And they use lots of different neurotransmitters in their synapses. So they're working their way around the opioid block. And that's the reason that opioid medications, which are medicines that are derived from opium, like morphine and Demerol, don't work very well in neuropathic pain, is because there's this short circuit, essentially, that's bypassing the effect of our typical narcotics. Now, I'm going through a lot of material, but please feel that, anytime you got questions, just pop in here. So patients that we see with physical pain, their pain might be nociceptive, like Godzilla, my kidney stone. It might be neuropathic. It might be inflammatory. Inflammation, redness, swelling, pain. People with bone metastases tend to get an inflammatory component to their pain. Patients with a bulky tumor in their liver and the Glisson's capsule, the membrane around the outer membrane around the liver that has a lot of nerve fibers in it, is really stretched, and that can cause an inflammatory pain syndrome. But the most common pain syndrome we see is a mixed. It's a combination of all these. Now, there's a lot of barriers to providing good pain control, and this is something that as hospice nurses you guys deal with all the time. First thing is people don't want to take narcotics because they're going to get addicted. They're going to become a drug addict. And people with severe pain, people with chronic pain, are at zero risk for addiction. It's just a very different kind of syndrome. So we need to really counsel them effectively that we're not going to cause them to become a drug addict. They are afraid of uncontrollable side effects, or maybe the family is afraid. And we need to reassure people that almost always we can get good pain control without making them over-sedated. And that if they do have some sedation, it tends to wear off and get better over time. We've already talked about constipation. Respiratory depression is actually more of a nursing issue, I think, because again, learning how to treat post-operative pain, it's drummed into you that it's going to make people stop breathing, and so you monitor their respirations. But in people that have chronic pain and are on chronic narcotics, respiratory depression is not a significant issue. A major barrier is a goal is not perceived as pain control. If you're worried about getting sued, and that's your primary goal, then you're going to say, well, I'm so worried I'm going to get sued, I'm not going to treat their pain. If you're worried about, you want to, you're afraid they're not going to be able to communicate with you, you're not going to see the pain control as a primary goal. Not seeking help. And this is probably the biggest one that I deal with all the time, is a misperception that the dying process is in fact a drug overdose. And this is your standard 500-pound gorilla problem. There's this 500-pound gorilla in the room and nobody wants to talk about it. The patient is dying of their underlying disease, but we can't deal with that, so therefore we'll blame the narcotics on the patient's decline. Now, when you do your physical assessment, what's the best way to assess if someone's over-narcotized? Pupil size. Somebody's over-narcotized, their pupils are going to be pinpoint. And if you go see somebody and they've got these big saucers for pupils, now if they've got glaucoma and they're putting atropine drops in their eyes, then obviously that's not going to work. Or if they've had cataracts ripped out, that's not going to work. But for the most part, and that's something you can teach the families. You know, get a magnifying glass and shine a light and show them that, you know, narcotic overdoses are associated with pinpoint pupils. The person doesn't have pinpoint pupils. Their decline is not caused by their narcotics. Again, you deal with this all the time. Let's talk about some of these opioid medications. These are narcotics that are derived from the opium that comes from the opium poppy. We talked about the big problems with meperidine or Demerol. Terrible narcotic, needs to never be used. Its major metabolite, normeperidine, is the worst for causing the myoclonus. And so that's the reason we shouldn't be using the drug. Codeine is probably the most constipating of all the opiate drugs. It really doesn't offer anything over the others, so there's really no particular reason to use it either. Hydromorphone or Dilaudid. Dilaudid is the most potent of the opioid drugs, meaning you can give the most effect for the smallest number of milligrams. And if your concern is volume, then there's an advantage to giving giving hydromorphone. So if you're giving somebody a continuous subcutaneous infusion and you need large doses of opiate medications, you'll probably get the most bang for your buck with the Dilaudid. But that's really its only advantage. Oxycodone was developed in recent years, less constipating than the codeine, much more expensive. It really doesn't add anything over any of the other narcotics other than it enriches the pharmaceutical industry, but it is in wide use these days. Fentanyl can be given intravenously, as it commonly is in intensive care units. We usually use fentanyl as a transdermal patch because it's a small enough molecule that it easily goes through the skin. It takes a while to get a fentanyl blood level once you put a patch on. The rate of delivery is affected by fever. We commonly have fever or fluctuating body temperature at end of life, which makes for erratic absorption. Fentanyl is you need a good supply of subcutaneous body fat to get the fentanyl to be absorbed, and a lot of our patients are very cachectic at end of life, so it doesn't get absorbed very well. So there's a lot of technical problems with using fentanyl. It's also very expensive. I'm not a particular fan of this drug at end of life either. The best of all the opioid drugs is morphine. And if you have to use an opium-derived drugs, you know, in terms of cost, in terms of effectiveness, it really is as good as all the others and doesn't have a lot of the drawbacks. The drug that we use for the most part at end of life, I think probably 80% of our narcotic use is methadone. Methadone is a synthetic narcotic. It was developed by the Germans in the 1930s as a narcotic to be used for pain relief. It is not derived from opium, so it doesn't have the metabolites that opium has. It kind of went out of fashion when morphine was developed. It was been used in the United States and throughout the world for drug addiction, for heroin addiction, as a substitute for heroin. And so it has a stigma associated with it that it's only used for heroin addicts, but that's not fair. It's actually been an outstanding drug for pain management. One of its big advantages is that it's lipophilic, and that the plasma membranes of our body's cells are fatty, and so this drug is rapidly absorbed across plasma membranes, which means it's absorbed very rapidly through the mucosa of the mouth and through the upper digestive tract. So it gets into the bloodstream very rapidly with an oral dose. Since it's not opium derived, we don't have to deal with the myoclonus. There's no toxic metabolites. It blocks the opioid receptor between that first and second order neuron, so it's very effective against nociceptive pain. It blocks those inner neurons with the other neurotransmitters, which makes it very effective for neuropathic pain. And it is the drug of choice for neuropathic pain. Now, the drug reps will try to convince you that Lyrica or Neurontin is the best drug for neuropathic pain, but by far, methadone is the drug of choice. And methadone is very cost effective. And the first time I gave the methadone talk to the hospital medical staff, the various pharmaceutical reps in the industry, in the community, did not want doctors to hear that talk. And so they put on big expensive luncheons throughout the city for the exact same time to try to minimize the number of people that would hear the talk, because they want to make their money selling OxyContin, even if it isn't as good. Methadone requires some skill to use. Its half-life is long and also very variable. That's a great advantage because it makes it easy to get a constant blood level of the medication. Average half-life is 22 hours, but there are occasional patients that half-life could be 100 hours. So if you're giving the medication every 12 hours and they are a very slow metabolizer, as time goes on, the drug could build up. You think you got them perfectly fine and comfortable, and then 4 or 5 days later, they start to get sleepy because they have a long half-life of the drug in their body, and the blood levels are going up and up. So it takes some skill and to recognize and to look for that delayed sedation. But however, for the majority of our patients, an every 12-hour dose is fine. A lot of our pharmacy consultants want to give it every 8 hours. The more times per day you give a medication, the less likely that they're going to be compliant and they're going to miss doses. I think every 12 is fine. The only time I would give it more often than every 12 hours is when you get this story that like 2 hours before the next dose, my pain starts to come back. And that might be they're a slow metabolizer and a short half-life, and so it's time, so you do need to go to every 8 hours. But that's a fairly rare patient. This way we're taught to treat postoperative pain every 4 hours by the clock is tantamount to waterboarding for patients at end of life. There's no reason someone should have to wait for hours for pain medication. What I do is I give 1/10 of their 24-hour dose every hour for breakthrough pain as needed. If somebody's on 5 milligrams every 12 hours, that's 10 milligrams per 24 hours. 1/10 of that is 1 milligram. Math is easy to do in your head when you keep it simple. And so I'd give them 1 milligram hourly as needed for pain. If they've had to take 3 or 4 breakthrough doses within a 24-hour period, then it tells us that we need to increase their every 12-hour dose to get them comfortable. Onset of oral action is about 15 minutes. Onset of oral action in morphine is about 30 minutes. So it's fast. So it's a good fast-acting narcotic as well. A milligram of methadone is a milligram of methadone, whether it's a 5 milligram tablet or a 10 milligram tablet or the liquid. We tend to like to use the oral solution. It's 10 milligrams per ml with a graduated eyedropper. It's easy to use. But some people don't like liquids. Some people don't like the taste of it. And from time to time, the various preparations are more expensive or less expensive. So if they want to use a 5 milligram tablet, that's fine too. It's harder to titrate the small doses with the tablets. Ideally, I'd like to have everybody on the same dosage. And drug errors are a big problem. Some pharmacies compound their own concentrations, and that's something we need to try to avoid and try to keep to the, if we're going to use the liquid, we want to all be using the 10 milligram per ml solution so the patients don't have different bottles with different concentrations, because that's a setup for an error. Approximately 50% of an oral dose is absorbed. So if the patient is on, can't take anything by mouth and comes into our inpatient unit, and we start them on subcutaneous methadone, and they're feeling better after a couple of days and their pain's under good control, we want to switch them to oral, then we need to double the dose orally. And we need to understand that every time we go from subcutaneous to oral or from oral to subcutaneous, different patients are going to absorb different amounts. So 50% is average. Somebody might absorb 30%. Somebody might absorb 70%. So we need to see how their pain is when we make that switch and be willing to make some further adjustments. We talked about this occasional delayed drowsiness, and that's for somebody that's going to have a long half-life. And so particularly a new patient, 4 or 5 days after you've started them on methadone, we need to assess for delayed drowsiness. Another problem with using methadone is drug-drug interactions. A lot of other medications will affect methadone, will affect its effect. Drugs that reduce methadone levels, alcohol, phenobarbital, dilantin, a lot of these medications. Always a good opportunity to talk to our pharmacists and make sure when we're starting somebody on methadone that there's no incriminating drugs that might be reducing the levels. Likewise, there's a lot of medicines that can increase methadone levels, and again, not necessarily things that we think of medicine. We don't think of alcohol as a medication. We don't think of grapefruit juice as a medication, but a lot of medicines, Tagamet, various antibiotics, diflucan, Prozac, all can increase methadone levels. So we can get in trouble with some of these drug-drug interactions as well. The FDA has come out with a warning about methadone. Came out in November of 2006. Being a suspicious person, I think the pharmaceutical industry had something to do with that. The pharmaceutical industry now pays most of the salaries of the FDA. FDA's job is to make sure every medication is safe and is effective. They have not done their job well and are under a lot of congressional investigation these days, and I think it's who's paying their salaries is affecting them. But at any rate, I think there are some good points in this FDA warning. And they report occasional death or life-threatening adverse effects due to respiratory depression or cardiac arrhythmias. The warning does not say the medicine cannot be used. It just says we need to be careful about it. And we're the experts at chronic pain at end of life. We should be the experts on the use of methadone in this venue, and so we need to be knowledgeable. So we need to understand how to dose the medication properly. We need to know about drug-drug interactions. We need to know about the people that have the long half-lives and may have delayed sedation. Torsades de pointe is a type of ventricular tachycardia, which is seen in patients who have underlying heart disease, who have underlying previous history of ventricular tachyarrhythmias, people who have prolonged QT intervals on their electrocardiograms. If you're going to use methadone for chronic pain, for somebody that has maybe chronic low back pain, they might live another 30 years, this is something we need to be very concerned about. If somebody is at end of life and they have uncontrolled pain, it becomes pretty irrelevant. But certainly I could see, even in an end-of-life situation, if somebody looks like they're going to live a few months and there are other narcotics available and they have a history of ventricular tachycardia, maybe we ought to try morphine first. But for the most part, that's not a big issue for us at end of life. But it is for other uses. The real bottom line is methadone is an extremely safe and extremely effective medication when used properly. It was a big sell 4 or 5 years ago when I first started lobbying for hospice to start to use methadone, and got a lot of pushback from the nursing staff. But one by one, when they had the patient with intractable pain and we switched them to methadone and we heard these words, I could tell with the first dose the difference. People began to realize how appropriate and important a medication it is for us. You got to do a little arithmetic here when you're trying to figure out starting somebody on methadone. And the usual story is they're on like 5 or 6 different narcotics. Again, this logic of portmanteau. If one narcotic at subtherapeutic dose isn't good enough, what do? You don't increase the dose? Nah. You just start them on a second narcotic at subtherapeutic dose. And then you put them on a third narcotic. So by the time they come to hospice, they're on 6 different narcotics. And you've got to figure out what the right dose of methadone is. You're not going to get it exact, but we need to get it close. If we give them too little, then the patient is going to, within a day, say, that medicine's useless. If we give them too much, then they're going to be drowsy, and they're going to not like the medication. So we got to get it fairly close if we want a happy patient. And so we have to do some math and look at all their medications, and we want to figure out how many milligrams per 24 hours of each medicine they're taking, and we need to convert that to a morphine equivalent. So if they're on a fentanyl patch, we take, and that's listed as micrograms, mcgs, and we multiply that times 2, and that gives us the milligrams, mgs, of morphine per 24 hours. So a 50 microgram fentanyl patch is the equivalent of times 2, 100 milligrams of morphine. Now if you look on the package insert, they give you a terrible calculation. Both National Hospice and the American Academy of Hospice and Palliative Medicine all speak against using that drug company recommendation and use the times 2 instead. Codeine is times 0.3, oxycodone is times 1.5, dilaudid times 4, some places say times 5, your choice. Demerol times 0.1. And so you add up all their narcotics, you do the math, and you come up with a morphine equivalent per 24 hours. And I've got an example here in a couple minutes. No calculus in this, no trigonometry, so I won't make it too bad. And then now you have to convert from morphine to methadone. And if you come up with greater than 1,000 milligrams of morphine for 24 hours, you divide by 20. If you come up with somewhere between 200 and 1,000 milligrams of morphine, you divide by 10. And probably 80% of our patients new patients that we see fall into this range. So that makes the arithmetic pretty easy. And if they're on less than 200 milligram equivalent of morphine per 24 hours, you divide by 5. The logic here is that people on large doses of opioid medications, there's a big neuropathic component to the pain, so adding all the extra narcotics isn't helping. So that's the reason for the difference in the conversion factors. So you want to start a patient that you think would benefit from methadone. If they are narcotic naive, then I generally start them on 5 to 10 milligrams every 12 hours. And I think we need to be looking at using methadone as a first narcotic more. Why start somebody on a less effective narcotic and then switch them to methadone later on? Why not put them on methadone up front? If the reason for the narcotic is just a small amount of intermittent pain, maybe a short-acting narcotic like morphine might be appropriate. But if they've got chronic pain, they've got an advanced malignancy, you have every reason to believe their pain's going to get worse over time, get them on methadone up front. If they have failed on another narcotic regimen, then we need to calculate the equal analgesic dose and start them on that appropriate dose of methadone. If they are comfortable on their current narcotic regimen, no matter how screwy it is, don't mess with success. You're never going to, if a patient is fine on what they're on, you're never going to get a buy-in, you're never going to make them happy by switching them to methadone just because it's our preferred drug. So wait for the progression and then make the switch. You're going to have a much more chance of good success. If the pain scores are consistently more than 5 after they've been on the medication for 24 to 48 hours, you need to escalate the dose, you need to escalate it aggressively, 50 to 100% increase. If you look at the World Health Organization pain scale treatments, they have this step ladder and a kind of a go slow approach. If you have chronic pain and a long life expectancy, that makes sense. If you're at end of life and you've only got a few weeks or a few months to live, then the quicker we can get you comfortable, the better. And with good follow-up and constant nursing interventions and a organization that is used to dealing with chronic pain, these are certainly safe escalations. Okay, here's an example. This is a gentleman we had a few years ago, police officer, 45 years old, malignant carcinoid, massive liver metastases. He was treated principally at Johns Hopkins and failed multiple different chemotherapy regimens. Despite multiple narcotics, he described burning right upper quadrant abdominal pain, which he reported 8 to 9 out of 10 for more than 6 months. So he's got burning pain. What kind of pain does this make you think of? Neuropathic pain. So he probably has a big neuropathic component to his pain. Currently, he was on 500 milligrams MS-Contin every 8 hours and oxycodone 10 to 20 milligrams every 4 hours PRN. Again, MS-Contin is a long-acting morphine, oxycodone. Why not just, if you're going to do this, why not just put him on morphine every 4 hours PRN? But you got to use multiple narcotics. But that's what he came to us on. I made a home visit and recommended that we switch him to methadone. He was reluctant because Johns Hopkins was opposed to it. But he finally said, it hurts so bad I'm willing to try anything, even though you're a dumb country doctor. So I added up all of his narcotics and I came up with approximately 2,000 milligrams of morphine per 24 hours. And again, on the 20-to-1 ratio, that came out with approximately 100 milligrams of methadone. You don't want to get down to milligrams or decimal fractions of milligrams. You do the math. Round numbers are close enough. So I figured he needed approximately, this was approximately 100 milligrams. So what I recommended is that we stop the MS Contin and we start him on 50 milligrams of methadone every 12 hours, and a tenth of that, which would be 10 milligrams hourly PRN for breakthrough pain. And he had the classic line, "I could tell with the first dose the difference." Outcome was that his pain scores were now 2 to 3 out of 10. He rarely required a breakthrough dose. His performance status, ECOG 3 means you're in bed more than 50% of your waking hours. 1 means you're fully active, although you have some symptoms. So he went from we were using the ECOG scale. We now use the palliative performance scale, and I need to change this. But his was scored ECOG because that's the way most oncologists score it. So he had a significant improvement in his performance status. And his line to me was, "Doc," he says, "there's 3 things in this world that are overrated: a home-cooked meal, sex out of town, and Johns Hopkins." And so I took that as a serious flattery. We talked about costs. This is 2004 data, and this is how much it costs an institution to provide 10 days of narcotics. Fentanyl is $250. OxyContin, $150. MS Contin, $75. Methadone, $15. So the cost is dramatically different. Methadone has been around a long time. The molecule does not lend itself to chemists tinkering with it, because the way the drug industry works is they tinker with a molecule and change it slightly, and then they patent it. And so methadone is very difficult for the pharmaceutical industry to patent a related medication. So it has stayed generic and has stayed nice and cheap. A couple other things to think about. One is ketamine. We haven't used ketamine but a couple of times in Coastal Hospice, but I think it's a drug of the future, and so I want you all to know a little bit about it. Ketamine is a dissociative anesthetic, and that means it causes profound anesthesia without sedation. Veterinarians love ketamine, to spay cats. And in fact, my first time I used ketamine was my girlfriend's roommate spay her cat on her kitchen table. She was a veterinary student. And give them a dose of ketamine, and they're anesthetized but still awake and breathing, and you can do what you need to for them. The problem with this dissociative effect is the dissociative effect can linger beyond the acute use of the medicine and beyond the anesthetic effect, and you get these out-of-body experiences, like your mind separated from your body, and then you turn back and look at yourself, and so it's like a bad trip, and so some people trip out. And so it has not been very popular for use in humans as an anesthetic agent, because we started seeing a lot of these persistent dissociative symptoms. Anybody watch the TV show House? Yeah, I've only seen a few minutes of 1 or 2 of them. It's kind of like a busman's holiday, I guess. But and Dr. House actually has, what his diagnosis is? Anybody? He has Asperger's syndrome, which is a mild variant of autism. People are often really weird and antisocial, but can be a genius. They think Isaac Newton had Asperger's syndrome, but you're going to get me off. I get myself off the subject. But at any rate, there was one of the House shows, and he has chronic pain, where he had an operation and he got ketamine, and his pain was controlled for months and months after the operation, just from that 1 dose of ketamine. So if you use ketamine at a dose much lower than its anesthetic dose, it has very good analgesia. And we recommend, if we're going to use it in the hospice setting, that we pre-medicate all the patients with Haldol, so that it helps block some of these out-of-body experiences and tripping out. Oral doses of ketamine, although it's usually, for anesthesia, it's given intravenously, but lower doses orally have a long effect of lasts about 6 hours, so it can be given orally. And you can start them on like approximately 5 milligrams 4 times a day, and then titrate to good analgesia, or perhaps the toxicity with these dissociative symptoms, with the maximum daily dose somewhere between 100 to 200 milligrams per day. And so you've got somebody that's on large doses of narcotics, large doses of methadone, for example. They're in our inpatient facility for pain management, and we're not controlling their pain. Adding ketamine is a reasonable therapeutic option, and I think we're going to see more use of this drug as time goes on. A lot of things to think about for non-pharmaceutical pain management. We talked about people projecting non-physical pain as physical symptoms, and so psychosocial and spiritual interventions are very important. Generally, when you're getting up to about 300 milligrams of methadone per 24 hours and you're still not getting good pain relief, a little light bulb should go off and say, maybe this isn't all physical pain. Even though it sounds like the pain is in their hip, maybe there's a non-physical component here. Surgical procedures, you're looking at an intractable pain that is quite localized, and maybe they might benefit from a peripheral nerve block. The celiac plexus is deep in the upper abdomen, and it's where a lot of the pain fibers from the pancreas come from. And so people with pancreatic cancer that have intractable pain, you could do a celiac plexus block. This is a pretty gruesome procedure. They've got these long needles that the radiologist places in the area deep in the abdomen through the abdominal wall with CT guidance, injects a little dye to make sure they're in the right area for the celiac plexus, and then they inject certain alcohols to try to kill this plexus. The procedure really is painful, and people are very sore for several days and have a lot of pain during the procedure. Some people have prolonged pain relief that could last for months afterwards. We had a young woman with metastatic pancreatic cancer within the last year who got an excellent response from her first celiac block, lasted about 4 months. They did it a second time and she got no benefit at all from it. Cordotomy, if you remember that fiber tract that goes up the spinal cord. How did that happen? The neurosurgeons can actually cut partway through 1/4 of the spinal cord and get that fiber tract, which is called the spinal thalamic tract. And so if you have patients that have terrible pain in one leg, they can do a cordotomy. Now that means that leg is going to be completely numb for the rest of their life. It sometimes is effective. It's a lot to do. We really want somebody that's going to live a while to benefit from a cordotomy. And there are some other neurosurgical procedures. It's not the first thing we think of, but once in a while, as I said, the cue is somebody that looks like they're going to live a while and they have very localized pain and it's really refractory to medications, or they have intolerable side effects from medications. They might benefit from a surgical procedure. Hypofraction radiation therapy, we're going to talk about that some more in a couple of minutes here, is another option. Again, when we consider these non-pharmacologic interventions other than psychosocial and spiritual, which should happen in every hospice patient, we really want the properly selected patient. We want somebody who has well-localized intractable pain, and we want to be sure that they're going to live a few months, so they're going to live long enough to benefit from these more aggressive interventions. Now let's come back to the single fraction radiation, and that's what hypofraction radiation is. Usual radiation treatments for patients for pain management is that they give many small dose fractions of radiation. It's problematic for our patients. It's expensive. It means the patient has to be transported back and forth to the radiation department. Obviously, one of these huge machines is not something you can take into somebody's home. And so it's not a particularly appealing treatment modality. But there is And there's also this tendency to, when they get them in the department, to treat other areas as well. And when you start, and most patients that are dying of metastatic cancer have lots of bulky disease in many locations in their body. But if our focus is on their symptoms, we really want to treat only the area that's painful because we want to relieve the pain in that area. A bulky mass of tumor someplace else in their body that's not causing them any trouble, radiating that area isn't going to make them feel any better because the area wasn't causing pain in the first place. And the larger area of the body that you radiate, the more fatigue you're going to get from the radiation. So part of the rules is that we want to treat only the area of pain. There was a big randomized trial, RTOG is Radiation Therapy Oncology Group. So 1997, trial number 14, randomized patients to get a single fraction of radiation. And the unit of radiation is called the Gray, named after Dr. Gray, who was a famous physicist. Either to give a single 8 Gray fraction or to give 30 Gray over 10 fractions. That's 3 Gray times 10 doses, which is what 90% or 99% of is currently done in this area. And the bottom line is 2/3 of the patients within 3 weeks had excellent pain relief, and side effects were less when they gave a single fraction. Now that should be enough. How much more data do you need? And this is a huge study, large numbers of patients. We ought to be doing this a lot. We are not. We are currently in negotiations with the new Henson Cancer Institute at Peninsula Regional for a contract for single fraction radiation, and hopefully we'll have that contract signed within the next few months. It certainly doesn't have to be a hospice patient. Ideally, this should be used more before in pre-hospice settings, but if we have a hospice patient who has one local area of pain, it's not going to work if they hurt in 10 places, but if there's really one area that's very troubling, look like they might live a couple of months, and we know there's tumor in that area, maybe their hip or their low back or their ribs, then the single fraction is appropriate. And our plan with this contract is the patient is going to be seen, simulated, and treated in the one visit. So they come to the department once, they get all their treatment. And give us another treatment option. Well, how about patients whose pain, despite all the things we've done, we're still not making any progress? They have absolutely refractory pain. One option for that is to consider palliative sedation, and that's the subject of a whole lecture, which we'll get later in this sequence, but certainly that's something that needs to be thought about. Transporting the patient to our inpatient facility often has a therapeutic benefit just from the change of venue, the extra attention they get, more aggressive symptom management that we can do in the home, parenteral medications, a whole host of reasons why a lake admission may benefit them. And we've had a lot of patients come to the lake for pain management from the home program and then sent back home a few days later. If the patient is in the hospital, we have a consultative palliative care service at the hospital. Can often help with refractory pain before they come to hospice care. Excellent reference this year from the Journal of the American Medical Association talked about management of refractory pain and recognizing that in this setting our goal is pain relief rather than fear of side effects, and it's okay to go ahead and aggressively use narcotics at end of life to relieve pain. So it's nice to see this not in a hospice journal but in the mainstream medical literature, because we're starting to get more recognition from conventional medicine for appropriate pain management. And that's all I have. I'd be happy to answer any questions from you ladies. Everybody's all quiet? Okay. Did I tell you anything you didn't know? Surprised? No? All right. Thank you very much. Next one is next week on the 15th.